in the long run, even looking at any type of program, I think the idea is identify a pilot program that you think can work. Take a chance. Don't be afraid to think outside of the box, you know, and identify something new, innovative, and take a chance. If it doesn't work, go back to the drawing board, identify what works, what doesn't, and move forward. And that's how we've done a lot in Illinois. It's been successful.
And where did you start with where's the low-hanging fruit, so to speak, as far as things that everybody can get on board with? Is it probably the higher system users like CHF or diabetes or mental health, alcohol abuse? What are things that really help get people on the same page?
I mean, a lot of this we haven't really identified. We're still in the infancy of our discussions, but all that we would take into account. But we're still in the talking stages of development.
Perhaps we just come back here. You know, we started to talk about this at breakfast a little bit. Just looking at the landscape, the Chicago landscape. You know, Eddie mentioned mental health. Do you want to maybe just?
You know, so we talked about low-hanging fruit. Mental health is a very complex issue, so I'm not sure that's the low-hanging fruit. I mean, I don't want to speak for Leslie or the first deputy, but you know, fall prevention is something very non-controversial and easy to roll out initially. Once we get that on board and make sure that it works, we get the kinks work the system, we move to a second phase of that. So what that is, we're not sure, but you know, it was mentioned, you know, diabetes, but at night you're coming in and just making sure their blood glucoses are running at a certain level. But once you get to that higher level, once you get to the level of resuscitation, then you can tackle something like mental health. At my particular hospital, we're a drop-off center for the north side for mental health issues. And we talked about this a bit at breakfast, but these people generally don't need another emergency department visit. What they do need is a place to go, access to their medications, a safe place, and you know, a hallway with crowded people is not necessarily a safe place. So as we kind of go on and we build partnerships with the city, whether that's Chicago Department of Public Health, various psychiatric agencies, just to figure out when, you know, if there is a call to the dispatch center and it's a person we've identified as a super user of mental health services, what is the best thing for that person at that time? Do we need to have, do we have somebody on call for like a crisis intervention to go out and see how they're doing, who can have an established baseline? Are they decompensated and really do need an emergency department visit? Have they just ran out of their meds and they need someone to fill their medications and that solves the problem? You know, once we get to that higher evolved state, these are things we can tackle. But I think at the baseline, we've kind of talked about, you know, fall prevention, very non-controversial things that everybody already has the skill set for. So not necessarily building upon an expanded scope of practice, using what we already know and applying it in a slightly different format.